when the state decided to deregulate the outpatient surgical center industry, meaning that they allowed these freestanding surgical centers to get built and licensed. That occurred in 1995. And it allowed physicians to build those surgical facilities. And of course, they required anesthesia for their procedures. With time, more and more of the cases were migrating from the hospital to these outpatient facilities, which has been a huge economic challenge to the hospitals themselves, but also to the anesthesia departments.
Welcome to UpMed, a journal of healthcare's race to the bottom, hosted by Dr. Erica Urquhart. Join Dr. Erica and her guests as they pull back the curtain and share a behind-the-scenes look at the healthcare industry, all while providing solutions for better patient care and management. Now, here's your host, Dr. Erica.
Thank you to our listeners for joining us for yet another episode of UpMed, the Journal of Healthcare's Race to the Bottom. I'm your host, Dr. Erica Urquhart, and I am joined today by an anesthesiologist who has a very distinguished career and is working in a private practice setting in a surgical center, the surgical center at Melbourne, and he's going to share with us his experiences. I'm working with Dr. Stillman today, and am truly appreciative that you've been able to join us. I would like to say that as we explore this saga in healthcare, we're exploring the concepts of the different individuals that I know professionally and their ideas that they've developed as they've experienced some of the changes that have occurred within the healthcare environment. So, Dr. Richard Stillman, thank you so much for joining us today.
Happy to be here.
Just so our listeners have an idea of what a distinguished individual you are, I'm just going to tell them a little bit about your background and your education. Dr. Richard Stillman is, as I said, the Director of Anesthesia Services at the Surgical Center in Melbourne. He is a founding member of this surgical center, as well as a physician board member. He did graduate work at Yale University prior to starting his medical degree and receiving his medical degree from the University of Virginia. He also has certifications and fellowship training in pediatric anesthesia, cardiac anesthesia, pain management, and acupuncture. Dr. Stillman is one of the most talented anesthesiologists that I've come across. He is able to give patients anesthesia in such a way that, especially in the surgical center context, if they do not want to go to sleep, they don't have to. And they can go home relatively pain-free with anesthetic that would last up to 24 hours, which means a lot when you're having, say, for example, in orthopedics, anterior cruciate ligament surgery or rotator cuff repair. We can't take for granted the skill that is required to complete such a task. And so certainly from a technical standpoint, Dr. Stillman, I say thank you.
Well, thank you for that introduction.
So just to get started, let us get familiar with one another in the podcast setting. If you had to pinpoint your professional niche, what makes you the go-to guy in anesthesia? What exactly is that?
Well, many in anesthesia are generalists and they do a little bit of everything, and the vast majority of anesthesiologists out there are pretty much categorized as generalists. As the director of anesthesia at an orthopedic surgical center, which focuses on any sort of procedure that involves bones, which includes podiatry, it includes hand surgery, and it includes standard orthopedics. I really subspecialized in doing that sort of work. And if I was to pick a niche that I'm really particularly good at, it's doing what's called regional anesthesia, which is a technique that really focuses on one part of the body. That's why it's called regional. We can essentially put to sleep your shoulder if you're having shoulder surgery, your knee if you're having knee surgery, your foot if you're having foot surgery. And that way we can avoid some of the side effects and perhaps risks associated with the big guns anesthesia, which is general anesthesia. We pretty much reserve that for major surgery where we're entering a body cavity like the abdomen or the heart. And certainly we can do that for this sort of surgery, but the big advantage is by putting a single area to sleep, a single region to sleep, we can administer the types of medicines that will last a prolonged period of time, yet they're safe enough to allow you to go home and be relatively pain-free for a good long period of time, lasting from 12 hours to several days. And that's a huge advantage because it allows us to do these sorts of procedures as an outpatient. Previous to these sorts of techniques being developed, patients would have so much pain and require so much pain medicine that they had to stay overnight in the hospital, which not only was riskier for them, more expensive for them, more inconvenient for them, and certainly more expensive for the insurance company. So that's my niche.
That's your niche. And I can tell that you're very passionate about it, very knowledgeable. And I think our listeners also get a sense of the degree of detail that's required to have this expertise. I suspect, although I could be wrong, that when you entered the field of anesthesia, you were not necessarily thinking that this was the area that you were going to pursue your career in. And the reason why I say that is number one, I think this field has developed significantly over the last 30 years. But number two, it may not be at the top of most anesthesia residents' lists. Was it at the top of yours?
Oh my goodness, no. That's why I did subspecialty training and fellowships in cardiac anesthesia. Boy, you can't do that as an outpatient. I've never done an open heart case as an outpatient, even with the training I've had. I also did a pediatric specialization. In my surgical center, we have regulatory requirements to only take care of patients over the age of 8. So the real youngsters who might be having ear tubes and tonsils and things, we don't even do. So I somehow migrated into this little niche. It evolved over time as I did more and more of these sorts of cases, and the more I was asked to participate, the more I kind of focused on them.
Yes, and I'm just curious, how does one make that transition from cardiothoracic anesthesia to hand surgery, foot surgery, knee surgery, shoulder surgery? What was it about anesthesia for orthopedics that drew you in?
When the state decided to deregulate the outpatient surgical center industry, meaning that they allowed these freestanding surgical centers to get built and licensed. That occurred in 1995. And it allowed physicians to build those surgical facilities. And of course, they required anesthesia for their procedures. So, with time, more and more of the cases were migrating from the hospital to these outpatient facilities, which has been a huge economic challenge to the hospitals themselves, but also to the anesthesia departments, because they were losing all these wonderful cases. Well, it turns out that the first kind of subspecialty that was very amenable to being done as an outpatient was elective orthopedic surgery. Obviously, emergency appendectomies and colon resections and heart surgery couldn't go outside electively. But boy, if you're having your knee arthroscoped because you have some knee pain, it's elective, it's low risk. And so orthopedists ended up going out of the hospital. And I was asked to really help start this particular facility. And the focus was to make it orthopedics. So I was more than happy to develop my already blooming interest in the field and focus on it.
That's fascinating. And um, as you mentioned, there are some specific issues pertaining to doing surgery at a hospital where your patients are primarily going to be inpatient, but could also be discharged overnight or the same day in some special circumstances. But there are also issues pertaining to doing surgery on patients that you know are going to be discharged the same day. From your professional standpoint, what kind of intensity is required to be a successful anesthesiologist in an outpatient surgical center like the one you are the director of?
You certainly, without patting myself on the back because I'm no better or worse than any of my colleagues doing the same thing, but it does take a very high degree of self confidence. You really have to know what you're doing. This is not something that even someone right out of residency or fellowship would be able to do. I am alone 90% of the 99% of the time in the surgical facility. And the skill set that it requires to deal with a critical incident falls completely on the anesthesiologist. Because as highly skilled as surgeons are, they really have long since forgotten the specifics of advanced cardiac life support and basic cardiac life support. I'm not insulting anybody, and I think they would agree. Most of them can't effectively read an EKG or administer the life saving drugs that needed to be administered, or intubate or resuscitate, or any of the things that, although low likelihood, you need to have somebody who can deal with that. And that's what the anesthesiologist's role is.
Yes, absolutely. I 100% agree with you about confidence and training. It's a very delicate balance. You don't want to be overconfident as an anesthesiologist because you want to be prepared and ready in case something does happen. And so you have to be hyper aware, hyper alert. But at the same time, you do have to believe that you are the patient's best doctor and that if something were to happen, you can handle it. Personally, our practice has been affected by the variability of anesthesia qualifications and comfort with regional administration, as well as with outpatient procedures in hospital affiliated surgery centers. And I wonder, what do you think the gaps are in training that create scenarios where you could have board certified anesthesiologists in outpatient settings who are uncomfortable with patients because they have a high BMI. For example, they may say, we're not doing surgery on this patient unless they lose 25 pounds for anesthesia reasons. When we all know the patient is going to have surgery, whether they lose 25 pounds or not. What are the issues with graduate medical education that create this variability in the anesthesia field?
Boy, that's a great question because it's something that we all have dealt with throughout our careers, and with so many advances in technology and such, it's impossible to master everything. And with the nationwide shortage of anesthesia providers, it's required us to bring up nurse anesthetists to a higher level of utility. And they, as good as they are, have even a tougher time keeping up with the niche little requirements. And some of them actually don't do some of these specified techniques. Whereas they might be even better than the anesthesiologist at some of the bread and butter things. When it comes to these higher level, broad based skill sets that you need today, like you're saying, at a hospital based outpatient surgical center, if my center was affiliated with a big hospital, I would have anesthesiologists of all levels and all different skill sets rotating through this center. And some of them would be able to do all these techniques that we've talked about, the regional techniques, and many of them wouldn't. Most of them have had experience with it, but there's a big difference in your success rate and complication rate when you do it all the time versus you do it once a month, a couple times a year.
Yes. Currently, you mentioned that, or I mentioned that you have a certification training in pain management, which would, in some ways, supplement your training and create more opportunities for regional anesthesia administration. What should an anesthesiologist who is looking to be in a position such as yours, what should they be looking to train in? How should they be looking to develop and hone that expertise so that they can avert the use of general anesthesia and provide the patients better outcomes postoperatively with effective regional?
Well, I will say that with all the techniques, for instance, ultrasound guidance, we didn't have ultrasound when I was training. So these techniques were all developed by hand and by understanding of the anatomy. When I would do these nerve blocks that people were able to go home pain free, we literally, I would put my fingers, I would say, here's the anterior scalene muscle, here's the middle scalene muscle, here's the interscalene groove. I have to place, by feel, place the needle. And now we have ultrasound, which literally it's like X-ray, less invasive. And it really takes much of the skill out of it. But now your everyday young anesthesia resident comes out with a huge experience in ultrasound guidance. So because this has become so important for the very things that you enumerated, there's now become a fellowship developed for anesthesiologists. If you want to do extra training and develop a niche like mine, then you can go and do a regional anesthesia fellowship, where all you do all day is find the cases that require these specialty injections and do them all day long. And so when you come out, you're really a pro. So, I would certainly look for somebody like that if I were to hire another anesthesiologist full time in my position.
Yes. Would you say that you are naturally skilled at regional anesthesia?
Huh. No. But am I good at it? Yes. And because I do for we used to keep track about 400 average of these types of nerve block procedures per year, and that doesn't include my pain management practice, which has analogous type injections. All of my procedures are done under X-ray guidance instead of ultrasound guidance, and so you really need to know the anatomy very, very clearly. And when you do, it certainly helps. But again, it's just, if I wasn't good at it after doing this number that I did, I really should retire. And I'm sure that many, many others are equally skilled, but there aren't many who do as many as I do unless they work in an orthopedic facility.
Yes. And so, to summarize, this is a skill that you learn to do successfully, well over time. And just getting to the personal aspect of that, any skill that's acquired now with your music background, you probably honed this muscle in your youth. But what personal qualities were required for you to be able to take on this role and to essentially learn on the job how to successfully treat patients so that they could have these surgeries without general anesthesia?
Well, I think it's an attitude that is fostered by the healthcare system successfully. It is every specialty can not only stop their learning at the moment they finish their training, you are required to continually keep up with learning. I've done easily 8 different cadaver courses, dissections over the years, to just during learning each of the procedures that I add to my repertoire. Every time there's something new, I'll take a weekend course with experts who are teaching the anatomy and the technology. And it's no different than everybody. You can't expect if all of a sudden if I were a urologist who trained more than 10 years ago, which is the vast majority, they did not do robotic prostatectomies. They never worked with a robotic surgical procedure, nor did you or your husband, both orthopedists, learn to do total joint procedures with a Mako robot.
Not with the
Okay.
Mako, but I did have an early robot in my
Oh, okay.
training. I'm young enough.
Oh, okay. Okay. Well, I'm quite a bit senior to you then because there were certainly no robots. And, the only way you could learn that now is to take coursework and then do it. See one, do one, teach one is the mantra and in medicine. And you have to be dedicated to improving your skill set. Otherwise you're going to be left behind and no one's going to want to work with you.
Yes, and I think that's just fascinating because what we're describing is an evolution and a transformation. You are not the doctor that you were when you graduated from residency, nor are you the doctor that you were when you finished your last certification. You're constantly evolving. And so, as you look back at your past physician self and your current physician self, having all of these years and experiences in between, what advice would you give the past physician self if you had to start this journey all over again?
I would recognize, I think I would tell myself that you really have to be into the process. And this sounds a little silly, but you do have to maintain realistic expectations, if not lower expectations. You really have to look in the mirror and see why you went into this field. And I'd like to think that I went in for all the right reasons, but to be perfectly honest, I wanted to be a scientist when I was in college and in graduate school, and I really expected to be going in to do medical science and ended up doing clinical medicine. And I held a very high expectation of myself, and I kind of felt like I was letting people down, all my mentors who were grooming me to be a scientist. And then I said, nah, I'm just going to be a clinician. And so I had a certain level of disappointment in myself. And so I was a little hard on myself then, and I think I held too high expectations. And I think I'd look back and say to myself, the only constant thing is change. You're not going to be able to predict it. You can do your best to prepare for it, but it's going to come when you least expect it, and you got to be adaptable. And if you're too rigid and not adaptable, boy, you're going to be unhappy.
Fascinating. Now, you're in a unique position because your wife is a nurse and you have two children that have followed in your footsteps in the pursuit of medicine, one in anesthesiology, and the other in a subspecialty in pediatrics. So, what advice did you give them?
Well, actually, my daughter started in pediatrics, and that's what you probably recall. She's actually an emergency medicine physician,
Yes.
and she's done. She's working out in California. And my son is in his last year of anesthesia residency. He's about to do a fellowship, like being cardiac anesthesia. And it's almost a little embarrassing for me because I feel like people think that I pushed him to do this. And the reality is, I really encouraged him not to do medicine. I really, early on in college and stuff, he was getting jobs in the business sector. He was traveling into New York City to work in the financial industry. Just didn't like it. Realized he had a skill set in science and ended up in med school and tried everything and realized, you know what, anesthesia fit the bill. And I was certainly happy for him. It's not for everybody. I wasn't sure it was for him, but he's really grown into it and feels pretty happy about it. So I'd like to think that I really didn't push my kids into this, but I think maybe genetically they have a predisposition to science and not the arts and languages. Their side of the brain is the science side, like me and their mother, and kind of a natural progression, I guess.
That's fascinating. We all say somewhere in our applications to medical school and sometimes in our applications to residency that we're interested in medicine because we're interested in helping people, making the lives of others better. Where do you think that objective or that goal falls within your current experience at the surgical center at Melbourne?
Well, I'm glad you asked that because I've been kind of asked that before, and I just wanted to throw my little experience in. I hope it doesn't shed a bad light on me personally, but that's not why I went into medicine.
Yes.
I mean, I started out wanting to be a scientist. I did research for 4 years during the summers in college. I did research for the year afterwards. 4 years of medical school, I did research every summer and every free period, published and did all sorts of things. And clinical was not my primary thing. It wasn't like I'm dying to help patients. But when I finally rotated through all the medical specialties in medical school, I realized, at least for me, the most scientifically oriented, bench oriented field is anesthesiology. It takes pharmacology. We use more medical technology than pharmacologic technologies than any other medical provider. Nobody even knows the medicines and mechanisms of actions of the things that we use. That fascinated me. That was some of the research that I had been doing. The other thing is the physiology of the body. And this is going to sound cruel and weird, and God, you're not going to want me to take care of you, but we always look at our patients in some ways as a lab experiment. I don't get to really establish a long-term relationship like most physicians do. I meet my patient the day of surgery, and I do look at my job as to immediately make them relaxed and confident of my skills, and that is a skill set. But ultimately, when they're on the table and asleep, I'm no longer having that emotional connection with them. And my connection is with their physiology. If their blood pressure isn't behaving the way I want it, I pharmacologically manipulate it. If their heart rate is fast, I slow it down. If it's slow, I speed it up. If they're conscious, I make them unconscious. If their muscles are tense, I give them paralytics. If it goes on and on and on. If they're anxious, I give them anxiety medicine. If they're in pain in the recovery room, they get narcotics. We have to understand these medicines and their interactions with everything else they're on, as well as all their underlying conditions in the physiology of what I'm doing that interact with their own physiology. That's science. And that's what I loved about it. So, am I the guy who's touchy feely, primary care provider, OBGYN, pediatrician, who has this really deep emotional relationship with their patients? No. But I do very much love and pride myself on the ability to make patients feel that I can take care of them and shepherd them through this scary experience. And that does take a personality skill set that I like to think that I've gotten good at.
Yes, I'm going to push back. You know, I like to push back. I'm going to push back on 2 points. One point is that all of the medical research, everything that we do, at the end of the day, part of it is for the expansion of the body of knowledge in the scientific field, but the other is so that it can benefit people who are either going to undergo surgery, undergo the pharmacologic agents that you administer. So that's the one pushback. I think you give yourself too little credit because that passion for science and the exploration of that frontier that will allow us then to be better clinicians, that is, I think, part and parcel of helping people. And then the other point that I wanted to make, and I hope I don't lose it, is that we do this, and in order for us to be really good, we do have to have that barrier, that distance between ourselves and our patients. Because if we're too close, then we can't be objective. And if we can't be objective, then we can't be effective. And then, when the emergency occurs or when, we need to make a critical decision, we don't have that distance or that ability, that capacity to really do what needs to be done in the moment. So, I would say you really love people. You may not agree with me, but I would say you really love people. You really want to make people better.
I do. I certainly do. I certainly have mourned with patients who have not done well. And I think it's one of the things that I enjoy about my pain management practice is that I do see patients in the office and do have a long-term relationship with them. I've got some patients I've been taking care of from a pain management standpoint for decades, literally decades, and watch them go through all sorts of life changes and events. And yeah, I really have developed emotional connections with these folks. But as far as an anesthesiologist goes, it's a completely different relationship.
I hear you. I hear you. And you mentioned a struggle, right? The struggle dealing with patients when, things don't go well. In your professional experience, in your entire career, is there one struggle, one challenge that sticks out for you?
In general challenge or one particular patient experience, I mean, certainly there have been many, many varieties of patient experiences, and we remember them very, very clearly. I certainly do. I've had what I consider three major outcomes that I obsess over that occurred maybe 20, 25 years ago. And I can remember the details of every one of them, and I struggled with myself as to what I could have done differently. I certainly lay some blame in my lap, but they were extremely sick, moribund patients. But regardless, I was the captain of the ship, basically, and they could have done better. And that, you know, that hurts.
Yes, yes. And I think we all have those experiences if we practice long enough, or even in training, sometimes we have those experiences. You know, I don't want to focus on the negative. Do you have any highlights where, you were the one that found that diagnosis, or you were the one that saved that patient? Or on the counterbalance, do you have an experience where you were reaffirmed by your capacity and your capability?
Honestly, too many to enumerate.
I love it.
It's true. I mean, that's something I do love about sometimes we're unheralded and unrecognized. But I know darn well when the patient's on the precipice of going over the edge there, and you save them. And many times the people around you recognize it, but and give you a pat on the back. But it's not really about the ego thing. There's been plenty of things that I'm very proud of having done, complications that have occurred in the center where I weren't my complicated, they were surgical complications, but the patients, trying to expire in the recovery room, and I'm there resuscitating them and taking them by ambulance to the hospital and screaming at the appropriate people to put them as the priority because I know what's going on and we don't have time to play around with your bureaucracy. They need to be in the OR right now. And that certainly has happened on two occasions. I've made a number of many times in my pain practice, I've made house calls to patients who've had issues at home where they were too sick after a procedure to make it into the office or even to get up to go to the hospital. And rather than get an ambulance, I just run over there and they're very grateful and I'm happy. And a lot of those things are very gratifying.
I'm happy to hear you say that. I want to end with this question, and it's a big picture question, somewhat related to the questions that we discussed earlier. But as we spoke about at the beginning of the podcast, you are the director of an outpatient surgery center where the emphasis is orthopedic surgery. And that's very different from operating rooms in the hospital or surgery centers affiliated with hospitals most times. What do you feel in the broad landscape of healthcare? What do you feel the importance and the role of a surgery center like the surgery center at Milburn is? Why do we need them? What purpose do they serve? What would healthcare be like without them?
Also, a good question. I think their indications and their reasons for existence has evolved. Initially, before the advent and deregulation of surgical centers, patients were an insurer, and the insurance companies were a captive audience. They had to go by whatever the hospital said. The hospital could charge whatever they want, and their level of ineptitude and inefficiency ended up causing patients and insurers enormous amounts of money. And we watched, the healthcare budget go skyrocketing in the mid 90s when it started to become a real crisis. Medicare became a huge part of the national budget. And so by going out to the community and building surgical centers, we could do things vastly more efficiently and without the bureaucratic nonsense. It used to be you'd go into the hospital, maybe you'd go the night before to be prepped for surgery. You had all sorts of requirements for preoperative testing that were expensive, time consuming, and delayed your care. Then you would stay in the hospital for several days afterwards and maybe not get discharged until your doctor could, break away from his office hours to come discharge you. And if he couldn't, you'd stay another night and, maybe you'd go home the next day. That just doesn't happen with a surgical facility. And you've all heard stories about people looking at their invoices from the details of their hospital bill, and they'll see a Band-Aid that cost $100 or something ridiculous like that. And that's
Yes.
just a way of the hospital diffusing the overall cost of the hospitalization, which is always enormous because of all the inefficiencies. So they put a $100 charge on the Band-Aid and think they're going to get away with it. In our facility, everything's kind of bundled. It's a single charge. The insurers can look at that and they get the best deal they can possibly get. They don't have to pay overnight charges. They know that we're very minimal in terms of preoperative testing, and I review everybody's records. I look at all of their history and physical from the surgeons before the surgery. And if I think that they need something that I don't have, I'll get it done. But more often than not, and this is where kind of the senior experience comes into play, if you're a young new anesthesiologist coming out, you're going to want to cover your behind with every test possible. And that's what happens in the hospital. But when you're senior and you realize what's really needed and what's not, you can do things very streamlined and very efficiently. We also surround ourselves by the best para personnel, our nurses,
Yes.
our administrators, our techs, our secretaries. We're a private little functioning unit, and we selectively groom our people to be the best they can be. We're a very tight-knit little regimen, like an army regiment. Everyone knows everybody else's workflow, and we do it very efficiently and economically.
That is amazing. And I appreciate your explanation because I am sure there are those that are in medicine and outside of medicine who learn something from your experience and your ability to convey that so clearly and succinctly. Well, this concludes this episode of UpMed, the Journal of Healthcare's Race to the Bottom. I've had the pleasure of speaking with Dr. Richard Stillman, the Director of Anesthesiology at the Surgical Center of Melbourne today. And I just want to say thank you so much for your candor, your eloquence, and your vast experience, and for you sharing your knowledge today, Dr. Stillman.
Oh, it's my pleasure.
Thank you very much. And we hope that you will consider joining us again for another episode of the podcast.
Sure will.
Thank you for listening to this episode of UpMed. For more information on Dr. Erica, visit her website at upmed.us and her LinkedIn profile at Erica Rowe Urquhart. To continue the conversation, visit and subscribe to our YouTube channel at E. Rowe Urquhart. And don't forget to hit the follow button on your favorite listening platform so you never miss an episode. We look forward to joining you next time on UpMed, a Journal of Healthcare's Race to the Bottom.